Good morning.
Good morning.
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 All right, I'm going to start by taking attendance real quick. Elnita,
Here.
Elise,
Good morning.
Annie,
Good morning.
Ashley Williams,
Good morning.
Brianna,
Brianna here.
Brittany.
Here, Roach.
Yes.
Oh, I'm here.
Brooke. Brooke Suter. Casey.
Here.
Caitlin.
Here.
Chambry. Courtney Leggett.
Here.
Courtney Meadows. Gabrielle Edwards.
Here.
Janelle Rogers. Jenna Mishu.
Here.
Jenna Sullivan. Jocelyn Nelson.
Here.
Juliet Ross.
Here.
Caitlin Walker.
Oh, I'm here. I guess there's two Caitlins in the class.
I'm also here, Caitlin Thornton.
Okay. Casey Colson.
Here.
Catherine Gant.
Here.
Kiana.
Here.
Kimberly.
Here.
Lauren. Lauren Turner. Leanna.
Here.
Logan.
Here.
Madison.
Here.
Brown. Waits. And Madison Rear.
Here. Madison Brown is here.
And rear.
Yeah, got it. Matthew.
Here.
Mackenzie.
Here.
Megan.
Here.
Olivia Adams.
Here.
Olivia Torrey.
Here.
Pamela Kennedy. Simone.
Here.
Sophia.
Here.
Taylor.
Here.
Tanya. Tanya Eason. Tracy Jackson. And Will.
I'm here. I'm here.
Here. Tracy Jackson here.
Okay.
Miss Amick, I'm here too, Brooke.
Okay, I'm going to go back through my absences. All right, so Brooke is here. Shambury.
Here.
Courtney Meadows.
Here.
Janelle Rogers. Lauren Turner.
Here.
Pamela Kennedy. Tanya Eason.
It's making Janelle exit the Zoom and come back in because her microphone wasn't working. She just asked me to let you know.
Okay. All right, is there anybody here that doesn't think I called their name?
Tanya Eason just put in the chat, I'm here.
Okay. Perfect. Thank you.
Miss Amick, I'm in section A08. Is this just for the Monday classes?
It is, but you can stay.
Okay.
I mean, it's going to be the same thing tomorrow. I'm just probably going to wind up posting this link.
Okay.
So,
Yeah, because
I
I
have
saw
a
it
budget.
too well. It wasn't, I didn't know if we were merging both of the classes or not. So I joined just in case.
Anybody else in that same situation?
I am. I'm in A10.
Okay, hold on just a minute. Okay, so if you're in the Tuesday class and you're here, one at a time, just tell me who you are.
My name's Emily Webb.
Okay.
My name's Kayla Rice.
Okay. Anybody else? Okay.
My name is Brittany Roach.
But you're in the Monday class, right?
Yes, ma'am.
Okay, I got you on the Monday roll.
Okay.
Great. Okay. Anybody else in the Tuesday class that's present? Okay. All right, so we're going to get started with our lecture, but I wanted to see if you had any questions about anything before I get started.
Pamela Kennedy said that she's here. Her microphone wasn't working.
Okay. I will correct that.
How for homework you say we had to do them case studies, but what are we supposed to do with those? I read the whole thing and read the question, but did we supposed to do something else?
Which case studies are you talking about?
The case studies that was on SurePath.
That's for sensory, correct?
Yes.
I didn't post those because that's not my content.
Oh, okay.
So, that would be Miss Oates.
Okay, I'll email her.
There should be a Dropbox. What are the rest of y'all doing with yours?
I just read it. I didn't know what to really do with it.
Yeah, there's not, when you read it, it doesn't like mark for completions like the quizzes that are due.
And there's
Yeah,
no
yeah, I got it. I thought you could go back and see it. Yeah.
I think
Okay.
last semester you guys just posted for us to study, because I do remember some questions off of there from the test. That's what was said last semester.
That's correct, Simone. That's what I did also.
Okay. So, that was put there just for your learning benefit then.
That's correct.
Okay. All right. Well, today we're moving past sensory into cellular regulation 1, and you have 2 content areas for cellular regulation. The first is diabetes, and the second is fluid electrolytes and acid base, which we will go into later. So today we're going to do diabetes. Now, for those of you in my pharmacology class, that's all the on-campus classes, let me reiterate that you will not have diabetes in pharmacology. So you will only be tested on diabetes in 155 for my sections of pharmacology. Now, I think Miss Turbyfill tests on diabetes and teaches on diabetes in her class. But since I teach both areas of content, there's no sense in me teaching it twice, if that makes sense. So everything you need to know about diabetes as far as medications and the disease process itself will be done in this class today. Okay? So let's start out.
I wanted to ask real quick, because I have your in-class lecture today for pharmacology. Are we meeting on campus, or are we going to also do a Zoom class?
You're going to do a Zoom because I'm quarantined.
Okay. All right. I'm sorry you're sick.
That's okay. Yeah, I can't come to campus, so we're going to be doing it via Zoom.
Okay. And are you going to email that link, or will it get posted on the D2L?
It's posted.
Okay. I didn't see it. Thank you.
Has anybody else not seen it, or has somebody seen it?
It's up there.
I did see
Okay.
it.
Yeah, I've seen it.
Okay. I thought I posted them at the same time, but I wasn't 100% sure, and I'm not definitely at my best right now, so just wanted to be sure. But yeah, it's already there for you. So what I'll do with both of these is I will take these recordings and post them for you.
Thank you.
Okay. So I don't know what's going on with my PowerPoint, but we're going to look at some things.
Ms. Amick, will this PowerPoint be posted, or do we just need to focus on that pocket study guide that was posted for diabetes?
The PowerPoint will be incorporated into the recording.
Got it. Okay.
And so if you have the recording, you have it all as we talk about it. Okay.
Thank you.
Sure. All right. So if there are no other questions, then we're going to go ahead and get started. Okay. So this is Marcela Torres. She is 57 years old, and she has no real prior health history, but she has come to her physician, and her statements are that she just doesn't feel well, that she's exhausted all the time. So at this point, you're going to be the nurse who is seeing her in the beginning. So tell me what you might want to know subjectively from Miss Torres.
How long she's been feeling that way.
Okay.
Any family history of diabetes, her history. as to
Okay.
medications and illnesses.
Okay, so let's say she's been feeling, we're going to call it puny, for approximately 3 weeks.
Her recent sleep patterns or recent stress or anxiety levels.
Okay. Not sleeping well. Everything else has been about the same. She works 9 to 5.
Maybe
She's a-
what her at-home glucose levels have been.
Okay, she doesn't have anything to take her glucose with. She's not ever had a need to take her glucose. She
What
does
about
really,
If she's like
Her-
staying hydrated, if she's eating properly, kind of like what her diet is.
her sister has diabetes. Somebody said something about, and her grandmother had diabetes. What else were you asking?
whether or not she's been, somebody said something about dehydration, drinking a lot, going to the bathroom a lot, urinating.
Okay.
What's her diet been like?
Her diet? She's just been on a regular diet.
Her activity levels.
She works 9 to 5 as an office clerk. She's up moving around during the day, going to the mail room, delivering things, going to the copier.
Is she on any medication?
Or any
She is
vitamins?
not on any medications. What was that last comment?
Or any vitamins?
No supplements, no nothing.
Any recent weight gain or loss?
Yes. Let me see. All right. So today we're not going to pay attention to this column right here. So today in the office, she was 214 pounds, and her last visit a year ago, she was 236 pounds.
So that's like unexplained weight loss, like without trying.
Right.
Any problems concentrating?
No. Other than the fact that she's just so tired, she doesn't want to do anything.
Any visual problems?
Nope.
Are there certain things that trigger the fatigue or different times of the day that she notices?
No, just generally she says she's feeling run down.
Feeling like dizzy or
No, just tired. No energy.
hmm.
All right, what about objective data?
Get vitals, blood work,
BGO,
BGO.
an ABC, a CMP.
All right, so we're going to start off. Let's make this a little bigger so y'all can see it. All right, so you want to get her vitals. So her vitals. What else do we want?
Her height and weight to do BMI.
Okay.
Her blood glucose level.
Her hemoglobin A1C.
Urine.
A skin trigger, her skin assessment.
What was that after A1C?
A urine analysis.
Urine.
Somebody said skin assessment, right?
Yes, ma'am.
Okay. Anything else?
Complete blood count.
Okay.
And metabolic panel
Yeah.
for electrolytes.
Okay. So you want a CBC and chemistry profile. Okay. So here's the lab work we have for her today. So she was 5'6", 214 pounds, BMI 34.5, sodium 144, potassium 3.8, chloride 98, CO2 27, BUN 23, creatinine 1.1, non-fasting BGL 237, cholesterol 207, triglycerides 192, LDL 117, HDL 40, WBC 8.9, RBC 5.9, hemoglobin 13.4, hematocrit 40.2, and platelets 352. Anything there that is questionable?
Her glucose level is high. And her BMI is high.
You said her BMI?
Yes.
Okay.
I'd like to see calculator anion gap too.
The BUN.
Triglycerides.
CO2 is low.
No, this is
Is
serum CO2.
oh, okay. I apologize.
Yeah, not arterial CO2. What else? I'm sorry. I'm trying to keep up with y'all.
The BUN is high.
Triglycerides is elevated. Cholesterol slightly elevated.
Her red blood cells,
What about them?
they're high.
What's your normal red blood cell level?
Is it 3.2 to 5.2?
It's 4 to 6.
Okay.
It depends on what source you go by. Usually 5.1 to I'm at 4.2 to 6.1. On some scales that might be a little bit high, but in her case, what do you know about all of her CBC findings?
They have to do with poor dieting.
They're basically normal. All right, so let's talk about this blood glucose level.
I have a question.
Yeah.
Could you remind me where you would find, like, which test would show like the glucose in the urine? Would that be BUN or?
No, that would be the urine analysis. Now,
Okay.
I didn't mark her BUN, I don't think, but it was a little elevated. Now, for this particular patient, why do you think her BUN might be a little bit elevated?
She might be dehydrated.
Okay, and somebody else said why?
I was
Peeing a lot.
Do what?
Is she peeing a lot? I can't remember if we said that.
Yes, she is. So she's peeing a lot, and so she is a little bit on the dry side. And so that's going to affect her BUN. Now, we have say random BGL. All right. What kind of BGL did she have done?
A non-fasting.
Fasting.
Non-fasting. So what does that mean? Where does that
Random.
fall here? Random.
Random.
So a random is just non-fasting. What does that tell you?
It could be higher than fasting, obviously, because she could have been eating.
I mean, she could have been
Okay.
eating
Not
something
accurate to diagnose anything with.
right before.
Right. So a random glucose, unless it's like extremely high or extremely low, is pretty meaningless because we aren't able to know what the patient's baseline is. And we're also not able to know what the patient has eaten in terms of the amount. She might say, oh, well, I had a burger and some fries and a Coke and some ice cream, but we can't really quantify that because let's say she had a Big Mac versus a quarter pounder. What's the difference?
There's more bread on one of them, I think. So the carb count would be different.
Okay, absolutely. So on your Big Mac, it has a bun and then a piece in the middle with 2 hamburger patties. And so that would definitely have more carbs than just a quarter pounder, which only has a bun. And we don't know how many fries she had or how much ice cream she had. We can't quantify it. So we can't really tell a lot about what's going on. And let's just say, even if she hadn't really eaten that much, if she's been sipping on sweet tea or Coca-Cola or whatever, then that's going to raise her blood sugar. And if she's just sipping on it all day, then it's going to keep her blood sugar up. So a random is basically useless to us. Now, how do these others differ?
Fasting would be your kind of your baseline. Usually they fast overnight and then come in the morning.
Okay, and what are the criteria for fasting?
I think it's 8 hours.
In most cases, especially for blood glucose levels, we can say a 6-hour fast. Now, is there anything that they can have on that fast that would not affect the fast?
Water.
Like water, black coffee.
Okay, water, black coffee, and unsweet tea. Just regular unsweet tea. Okay. What about preprandial? What does the term prandial mean?
For a meal.
Okay. Prandial means mealtime. So preprandial would be before the meal, and postprandial would be afterward. Now, a preprandial is usually done immediately prior to eating. And then postprandial, we can do postprandial a lot of different ways, but do you know what the most common way is?
2 hours.
2 hours.
Yes. Now, why do you think that is?
It takes time to digest the food.
Right. The blood sugars are going to spike when they first eat.
Okay. Well, we know that within 2 hours after eating, our blood glucose should come back less than what? $140.
100? No, 140.
I have
So
a
yeah,
question.
it'll be 140. We want them to be back really close to their baseline. What was your question?
So this might just be my mother being bad, but my mother's a type 1, and immediately after she eats, she gives herself a bolus. Is that not correct?
No, it is.
Oh, okay. So you can
Yeah.
do it. It's usually 2 hours after.
Well, we're just talking about assessing blood sugar.
Okay, gotcha.
So yeah, we'll talk a lot more about medication dosages, which would encompass what you're talking about. But for right now, we just want to define these couple terms. So your random is just any old time. So they walk into the ED and they get their labs drawn and we get a blood sugar. But we don't really have anything to compare that to. The fasting, as long as they've been 6 hours, then we get a good idea of what their baseline is. So that fasting is usually what the patients check the most, and it's usually checked upon rising in the morning before they eat their breakfast. And then we have preprandial and we have postprandial. Now, in the hospital, we don't necessarily do a whole lot of postprandials, but we do a lot of preprandials. So we're going to be talking more about that a little bit later on. So what types of questions would we want to ask this patient about risk for diabetes?
Miss Amick, I have a quick question.
Yeah.
For the fasting and the preprandial, in the morning, would those two be very similar since it's done before eating, or will they be really different?
It depends, but they should be fairly congruent if their medication or if their treatment is appropriate.
Okay, thank you.
Yeah. So if they are compliant and their treatment is appropriate, then after they eat, their blood sugar should return to a baseline that's fairly similar. So let's talk about let's talk about risk factors for diabetes first.
Family history of it.
Okay.
High blood pressure?
Renal disease.
Bad diet.
Lifestyle.
Okay. Let's talk about risk factors. What are risk factors?
Things that predispose her to an illness.
Okay. Something that a factor that a patient has that puts them at risk for the development of a condition.
Obese, overweight.
Okay. So we're looking at modifiable and non-modifiable risks. So we're going to put, from what you just said, we're going to put obesity.
Ethnicity.
And what did you say?
Ethnicity.
But not blood pressure?
Age.
I'm going to put blood pressure because we're going to talk about that.
I said blood pressure.
Yeah, I know. That's what I'm saying. I'm going to list it as a risk factor, but it by itself is not a risk factor. But it certainly is when you combine it with other factors.
Anything that's currently wrong with the pancreas.
Is
Maybe.
it blood pressure, cholesterol, and then you more likely have diabetes?
That's part of it.
Inactivity.
So we could put, let's put instead of cholesterol, we're just going to put lipids.
What about a female who has a history of gestational diabetes?
Okay. I'm trying to get it all in here. So if you said something and I didn't get it, you'll have to tell me again. So I put inactivity with obesity. We're going to put a history of gestational diabetes. Anything else anybody has said that I didn't get?
If they're a smoker or like alcohol consumption.
So smoking and alcohol consumption by themselves are not risk factors for diabetes. What do we see though with
Hypertension.
okay, they may cause hypertension. There are other health problems that come along with those activities that can influence diabetes.
How
But they
about
aren't.
anybody with a metabolic disorder?
Define metabolic disorder.
CKD. Chronic renal issues.
So with
Someone who's
CKD,
maybe not immunocomp, or like someone who has like cancer or something like that, or suffered another medical problem that might contribute to their body not being 100%.
okay.
I was gonna ask if like pancreatic cancer could cause it. I didn't know. I was just gonna ask.
Yes, but that is secondary diabetes and not primary. In other words, that would develop because their pancreas can't produce insulin. But the reason would be because they have pancreatic cancer. Now, going back to the CKD, does chronic kidney disease cause diabetes or does diabetes cause chronic kidney disease?
Diabetes would cause chronic kidney disease.
Okay.
What about heart disease? Is that a risk factor?
We're going to put that up here with lipids. Because when we say heart disease, basically what are we talking about?
Like atherosclerosis.
And what is the cause of atherosclerosis?
Cholesterol.
Yep, cholesterol and lipids.
Yeah. Yeah, those lipids. So it all kind of goes together, and we're going to talk more about that. So let's go back to family history. When we say family history, what are we talking about?
Your mother, father, grandparent.
Immediate relative with the history of diabetes.
Okay, so we're talking about a primary relative. So that would be a sibling. Yeah, first degree, a parent, a sibling, a child. Right? Is that it? Parents, siblings, and children. Those are all first degree. Anything beyond that, it's nice to know. And it doesn't mean that they're not at risk, but the highest risk is if you've got that primary family member.
Does it matter what type of diabetes for the primary family member?
Basically, we're talking about type 2. All right. What about ethnicity?
African American.
Okay.
Hispanics.
American Indian, I think, are predisposed.
Okay. Those are our top three. Now, different sources will tell you different things about who's most at risk as far as ethnicity. But we see more African Americans with type 2 diabetes because we see more African Americans typically. I mean, how many of you have taken care of an American Indian? Not most of us, not much.
Once.
Not unless you live in specific areas of the United States like North Carolina or
Myself.
Huh?
I said I take care of myself.
Oh.
I'm
I have-
Native
I was gonna
American.
say, does my husband count?
I had one from Alaska who was a transplant.
Okay, yeah, and we have to remember that our Alaskans are included in Native Americans. Let me put that on there because that's a good point. And then your Hispanic population. Hispanics actually I think I'm right in that Hispanic numbers have taken over African American numbers with diabetes.
I'm pretty sure that's correct.
Yeah. Let me see what ADA says about it.
Could that be more of a cultural thing? Not that they just become more, not that it's happening more often, but like I know with my friend who's from Honduras, they will not go to the doctor. So they may have diabetes and they don't even know it.
Correct. And some of it does have to do with cultural influences.
Unknown caller.
But so this is listed by percentage. So I'm just going to put it here so that you can have a visual. So with African Americans that are considered non-Hispanic African Americans, the rate is 11.7%. Now, I'm getting these statistics from the American Diabetes Association. So these should be up to date and these are reliable. Your Hispanic population is 12.5%. American Indian, you want to take a guess, higher or lower?
Lower.
Higher.
Higher.
They're gonna come there. They've combined it. So let's combine Alaskan and American Indian. 14.7%. And then following behind that, we have let's see, Asian Americans. And they are 9.2%. And then whites are 7.5%. You can see from these statistics that our Native American and Alaskans are very high comparatively, followed by Hispanics and African Americans. But our African Americans and our Hispanic populations are very, very close. So this goes back to what somebody was talking about, in that some of this is genetic and some of this is cultural. But now, if we had to think about cultural, which one of these is surprising as far as culture out of the list that I gave you right here?
Whites.
Okay, what about white?
Alaskans and American.
It's American Indians.
American Indians, yeah.
I feel like the Asian Americans is kind of surprising. I feel like they usually have a pretty healthy diet.
Okay. Correct. That's what I was looking for. Asian, tell me about your typical Asian diet. Now, I'm not talking about United States Asians, okay? I'm talking about typical Asian countries. Tell me about their diets.
I mean, there's a lot of carbs.
A lot of rice.
Rice?
They usually aren't like, they don't have like, usually like, I feel like a lot of chicken. They don't have like a lot of meat that would raise your cholesterol or anything. And they're also very active usually.
They eat a lot of fish.
They usually use a lot of like soy products though, also like soy sauce and like different sauces.
Okay. But basically, they eat a lot of fish and vegetables and rice.
Yeah, but they fry a
They're
lot
not
of.
really big on sweets over there, though, right?
They don't eat as
No.
much as Americans eat though. When we would go eat Chinese food or whatever, they're more
Well, and
conservative with their portions.
when we eat Chinese food too, we're eating a lot more fried stuff.
I was about to say,
So that's what I'm
Americanized.
Americanized Chinese is like sugar chicken.
Exactly.
I mean,
Exactly.
they eat a lot of like unfried rice, like white rice.
Right. And, a funny thing is, fortune cookies are an American thing. They didn't come from China. Did you know that?
No, that's kind of interesting.
Isn't it though?
It
That's
does
not.
surprise me though.
And a lot of our Americanized Chinese food is a lot a lot more fatty and a lot more unhealthy. Now, used to be that in China you didn't see a lot of obesity. They were typically very healthy and weight controlled. But nowadays, we can, if you go and read about it, the obesity rates in China are increasing. Why is that?
Isn't a lot of the blame around like McDonald's and fast food chains infiltrating places other than America?
They're
Absolutely.
adopting that American diet.
Okay, that's very true. And what do you know what restaurants are seen most in China that are from America?
I would say McDonald's and Burger King.
Okay, that's two of them.
KFC?
KFC and Pizza Hut. And so what we're seeing is that because Americanized food has moved into some of the Asian countries, the Asian rates of obesity and consequently diabetes have gone up. And so that's what we're seeing.
My family's
So,
they have the same problem with the McDonald's and Pizza Huts moving in.
I'm sorry, what did you say?
So my family's Greek, and we have the exact same problem with McDonald's and Pizza Hut coming in and changing obesity.
Oh, into Greece?
Like you go to the major cities like Athens and things like that. I mean, obviously not in the villages, but they are taking over and they're having obesity problems.
Yeah, and what do we know about Mediterranean and Italian diets?
They're pretty healthy.
Yeah, they've traditionally been very healthy because they're vegetable based and lean meats and seafoods and um, things like that. So there again, when you think about traditional Mediterranean and Italian diets, especially, they're healthy and they're also more cancer preventative. Whereas all these things that we eat are not cancer preventative. So, anyway, that's just a little brief discussion on ethnicity and how it relates to diabetes. Are there any other risk factors that we should put up here?
Can medications be one, like certain medications you're on increase your risk for it?
I'm going to say yes, but not for primary diabetes, but
Okay.
for secondary.
Okay.
For example, steroids.
Yeah, that's what I was gonna say. Like,
Yeah, we'll talk about those in just a second. I wanted to talk
okay.
about the types of diabetes, but definitely medications can.
Okay.
There's one more that I'm going to put on here is a history. Whoa, that's so tiny. History of delivering a baby.
Would that go along with like a hormone imbalance?
Tell me what you're thinking.
Like I know a lot of women with like polycystic ovary syndrome can develop diabetes and like other hormone imbalance like diseases.
Yes. Excuse me, especially when you're talking about PCOS. So that would I don't think that would be a risk factor as much as it would be considered a comorbid condition. In other words,
Okay.
they kind of occur together.
Yes.
Now, this doesn't mean that every female that has a baby that weighs more than 9 pounds has diabetes. But what it means is that if you have a large baby, 9 pounds or more, that it could be a risk factor for becoming diabetic. Now, moms who are diabetic or moms who have gestational diabetes, two different things, who get pregnant have a potential to have large babies because if their blood sugar is high, then that baby's going to get more food and it's going to grow more, so it's going to weigh more. So it's directly related to the amount of glucose that's in mom's system. But not everyone who is diabetic has large babies. So that alone is not enough to say you're at risk, but it's certainly something worth investigating. So I am diabetic now. I was not diabetic when I got pregnant, but I had gestational diabetes twice. The first time my baby was 7 pounds 5 ounces. The second time my baby was 8 pounds 6 ounces. So neither were greater than 9 pounds. But I still wound up with diabetes. I was also on insulin for 9 weeks with my second one. And they took him early because they knew he was going to be a big boy if he wasn't born early. He was already 8'5". So that's kind of a relative statement. But what it's saying is that if you have a mom that delivers a baby that's 9 pounds or more, she should be worked up just to be sure that she doesn't have diabetes. Does that make sense?
Yes.
Okay. So out of all of these risk factors for type 2, which one do we see most often?
Obesity.
Obesity. Very good. So obesity is the one thing that we see that's usually a commonality. And why is obesity important for us to focus on?
Your midsection.
You can
Okay.
change in the reverse if you take the time. Well, not an easy thing, but it's something you can reverse.
Okay. So yeah. So we look at obesity. It is the primary risk factor for diabetes. And the thing about it is modifiable. And it actually is a direct cause of type 2. So let's talk about the metabolic syndrome. Okay. So the metabolic syndrome, believe it or not, is not something that's been around a really long time. It has come about probably in the last 50, 60 years. Maybe not even that long. But the metabolic syndrome is a group of criteria that when you have 3 out of the 5, it means you're at higher risk for diabetes and for heart disease. And so we look at these criteria when we're evaluating people for overall health. So you can see for patients with increased waist circumference, and let me just say that with the metabolic syndrome, we're basically, when we're talking about body shape and obesity, we're talking about those apple-shaped people, which is where I fall. Because apple-shaped people have more round bellies and not so much in their chest and their arms and their legs. So they're more apple-shaped. And our apple-shaped people are the patients that we see with increased waist circumference. So for men with a waist circumference greater than 40 and women with a waist circumference greater than 35, that's a risk factor. With your triglycerides, a triglyceride level of greater or equal to 150, or you'd have to take medications to keep your triglycerides low. That's a risk factor. Your HDLs or high density lipoproteins, men should be greater than 40 and women should be greater than 50. And then blood pressure And these criteria for blood pressure on the metabolic syndrome might have been a little bit adjusted, because when we talk about perfusion in a couple of weeks, we're going to talk about that the American Heart Association has changed or decreased what a normal blood pressure is. So 130/85 is considered relatively high now. So those numbers may have dropped even lower. But if your blood pressure is greater than 130/85, or you have to take blood pressure medications to keep it below 130/85, that's another risk factor. And then a fasting glucose greater than 100. So if you have at least 3 of these, then you're considered to have the metabolic syndrome, which, like I said, is a huge risk factor for both cardiovascular disease and the development of diabetes. So, how many of those things can we modify?
Waist circumference, triglycerides, blood pressure.
Cholesterol.
All of them, right?
Yeah. So all of these are modifiable. So metabolic syndrome is one of those things that doesn't take into consideration those non-modifiable risk factors like ethnicity, because they're applying it to all ethnicities. And basically, with some healthy choices and lifestyle management, we can most likely change all of those, at least somewhat. Now, what I mean by that is, take, for instance, your lipids. Some families are just prone to have high lipid levels in their genetics. So they may maintain high lipid levels, but hopefully with some lifestyle choices, they can be brought down some, even if they're not brought down into normal levels. But this metabolic syndrome is just important in identifying those patients who are most at risk for diabetes and heart disease. All right, we talked about subjective. We talked about objective. We looked at the labs. Now, we talked about random blood sugar, fasting, preprandial, and postprandial. How does that relate to the A1C? What is the A1C?
I know it's able to like find out like if you've been eating bad over more than just right before you take it. I know, like my mom always goes, "Oh no, they're gonna get me on my A1C." It's able to see what you've been doing.
Okay.
As with your
How does that
hemoglobin.
happen?
Does it show your blood sugar trend over the past like 3 to 4 months, like your average levels, and it turns it into a percentage?
Okay. Yes. So here's how that works. You know that hemoglobin is on your red cells. So that's part of one of the components of your red cells. Red cells, you get red cells every day. You make them. And every day you have some that die. So what is the interesting thing about red blood cells?
They carry glucose.
Okay, they do pick up glucose. But red cells are really interesting because they contain suicide genes. And those suicide genes program them to automated cell death. So, how does cell death work with red blood cells?
They're pre-programmed, is what you're saying?
Yes.
When they start getting weak, they kill themselves.
Well, how long does a red cell live?
120 days.
120 days. So they are genetically programmed so that after 120 days, on the 120th day, basically what happens is ticking time bomb says your time's up, and they undergo what process?
Is it apoptosis?
It is apoptosis. So apoptosis basically means that their cell wall just explodes or disintegrates, and so there's nothing to hold them together, so they die. So if we're looking at a red blood cell, we can tell that that red blood cell is no more than 120 days old. Because if it was more than 120 days old, it would be dead, and we wouldn't have it anymore. So when we draw blood and we look at those red blood cells, we can see how much hemoglobin was in the blood when red blood cells were formed. When red blood cells form, they take on glucose, and it becomes what we call glycosylated hemoglobin, or glycolated, depending on which source you're looking at. So glycolated means that the hemoglobin has picked up whatever concentration of sugar was in the blood at the time it was made. Now, when we look at a glycosylated hemoglobin, we're looking at all the cells that have been made in the last 120 days. So that gives us an idea of what the blood sugar has been over that 120-day period. And that's how we get our hemoglobin A1C, or glycosylated hemoglobin. So I call it the tattletale test, because you might be able to eat right a couple of days before you have to go for your doctor's appointment to get your blood sugar normal, just by eating a low sugar diet. But you can't trick them with your A1C, because unless you've been eating healthy for the last 120 days, or most of the last 120 days, then your blood sugar will affect your hemoglobin, which is going to show up in your A1C. So basically, just to kind of reiterate, the A1C provides a practitioner with the average blood glucose level over the last 120 days. Any questions about that? So if your blood sugar was high when your red cells were made, they will contain more glycolated hemoglobin. indicating that your sugar was high. So out of all of the tests that we could do, random glucose, fasting glucose, preprandial, postprandial, and whatever else, out of all the tests that we can do, the A1C is the most reliable because it tells us what that blood sugar has been over a long period of time, not just today or yesterday or the day before. So when might we want to use an A1C?
After
When
starting
you-
some insulin. Or
Okay.
medication.
After somebody starts treatment, medication, insulin, metformin, whatever, we can use the A1C to make sure that the treatment that we're using is working well and is appropriate.
Would they use it for the diagnosing phase too?
They would. Because if somebody comes in with a really high glucose, we don't know what's going on. It could be medication. It could be diabetes. It could be that they just went out and gorged themselves on, sugar. We don't know. And that's why a blood sugar at that point is not going to be the absolute best thing to look at. But if we look at that A1C, how is that going to help us?
Because then it'll show the average instead of just like what's going on right now.
Yeah, it's going to tell us what's been going on for the last 120 days. So let's look at what that looks like. When you educate your patients, it's really kind of funny when you show them what their A1C actually means and they understand it. They realize then that trying to trick somebody or misbehave with your sugars is not something that you can do if you're going to get your labs checked. So if you just look up A1C conversion, let's see. Let's go with, let's just look at this one. Okay. So when you look at this chart, we don't really go by millimoles, so don't pay attention to the millimoles. But what you want to do is look at the hemoglobin A1C, and it will tell you basically what the sugar is on average. Now, what does it mean to say that something is on average?
It takes a bunch of different numbers and groups them together and divides it.
Okay. And when we look at the average number, the result that we get, what do we know about it?
Sometimes it's higher or lower than that number.
Absolutely. So sometimes it's higher and sometimes it's lower. So we really want it to be average enough where your lower number is still within normal range and your higher number is still within normal range. So what is the range?
4 to 6 or less than 6, 4 to 6.
Okay, so your A1C, we want it to be, basically they say for diabetes less than 6. I mean for non-diabetic less than 6. But for blood sugar, we want it to be between 70 and 99. So we're looking at, we want their blood sugar fasting to be between 70 and 99. And we never really want their blood sugar to be above 200. Why?
DKA.
Okay, DKA. When the blood sugar gets above 200, the concentration of sugar is great enough that organ damage and other types of damage start to occur. So our goal is to keep our average well enough under 200 that the higher level of that average doesn't really exceed 200. We really want to keep our blood sugar below 200 at all times to keep from damaging our kidneys and our eyes and those kind of things. So looking at this table, if we had an A1C of 8.4, that would mean we're looking at our milligrams per deciliter blood sugar level. That would mean that we were 222 on our blood glucose level average all the time. So sometimes it would be above 222, sometimes it would be below 222, but basically we're already above what we want it to be max for our average. When you look at 6, your blood glucose average is 136. And so that gives you plenty of room to stay under 200 when you're highest, and plenty of room to stay above 70 when you're lowest. So that's why we want to see A1C levels for a diabetic that are between 6 and 7. So if your diabetic stays between 6 and 7, you know that they are exhibiting good control. So what does good control mean?
Their diet is controlled.
Okay, diet is controlled. What else?
They're using their insulin like they're supposed to.
Okay, their treatment is correct. In other words,
Weight
they're
or
getting the right amount, and that they are compliant, which is, I think, what somebody just said. So we can tell that their treatment is appropriate, that they understand their treatment and know how to take care of themselves as far as medications and diet, and that they are compliant in doing that. So normally, on most diabetics, they get their A1C checked twice a year. It doesn't do you a whole lot of good to check it very often, because if your blood cells are going to live for 3 months, checking it less than every 3 months is not going to give you a very good assessment. You're pretty much going to get the same thing. So really checking it twice a year, every 6 months is good enough. So when we check this, and you can see down here at the bottom, tells you what that these red colors, these dark, are suicidal. Because what that means is you're killing yourself. Some of y'all have heard me tell this story before, but my daughter was a dancer. And she had this dance teacher who was a severe type 1 diabetic. and she loved Krispy Kreme donuts. And she would eat them without a whole lot of restraint. Let's put it that way. And she was laughing one time because she had been to the doctor and her A1C was over 14. What do you notice about that?
It's off the suicidal chart.
Yeah, it's not even on the chart. And I was sitting there thinking, dude, that is not funny. Because, and she was young, probably 30-ish. And I'm thinking, you're going to be on dialysis and have lower extremity amputations before you're 50 years old, if you're still alive. Because you can't live with an A1C that indicates that your blood sugar is at high all the time, because you'll wind up blind, on dialysis, with bilateral lower extremity amputations. Because high blood sugar damages blood vessels. Yeah, we have blood sugar in our blood at all times. And it's fine as long as it is at a normal level. But once it becomes an abnormal level, then it starts to damage microvasculature, little tiny blood vessels. And what that does is it damages the glomerulus of the kidney, and it damages the blood supply and the nerve supply to the extremities. And so people wind up with peripheral neuropathy, blindness, and amputations from vascular disease. And so that's why it's so important for our diabetics to keep their sugars such that their A1C stays up here in these ranges right here. So most physicians don't look at daily blood sugars if they can evaluate the A1C and the A1C be normal. Now, I don't want you to think that blood sugars, excuse me, I don't want you to think that A1C levels have to be 6 or above with a diabetic. Because some diabetics, I've had an A1C before of 5.6, 5.4, which, in all honesty, most sources would say that is non-diabetic, but it basically just shows that the person has very good control. But if the patient is between 6 and 7, then we're happy with that. Once it gets above 7, then we need to look at the treatment, or we need to look at the compliance, or we need to look to see if that patient has an illness going on. So any questions about the A1C? All right. Well, let's talk about the types of diabetes real quick. There are basically 4 types that I want you to know about. Now, 3 of them you kind of need to know all the time. The other one you're going to see mostly in OB-PEDs. So we have type 2. We're going to talk about type 1 just by definition. All right. Type 1 is, the old term for it was juvenile onset. We don't really use that term anymore. What we use now is either type 1, or you may see it as what we call IDDM, or insulin dependent diabetes. So in this disease, we have failure of the pancreas to make insulin. So the pancreas will never be able to produce insulin. And what's happened in this disease is that through an autoimmune process, this is an autoimmune disease, through an autoimmune process, the beta cells in the pancreas have been destroyed. And those beta cells are responsible for making insulin. So once they're destroyed, we don't have any way to make insulin. And so the only way we can survive is to get our insulin from outside the body, or exogenous insulin. Then we have our type 2. Now, type 2 is a little tricky in that it might be that our pancreas isn't making enough insulin, or it might be that we're insulin resistant, which is the biggest cause. I'm going to put insulin resistance versus decreased insulin production. Or both. And as patients age, they're more likely to move from just insulin resistance over to insulin resistance with decreased insulin production as their pancreas ages. And I'm going to go back and we're going to talk about what insulin resistant means, insulin resistance. But just know that most type 2 comes from insulin resistance, and insulin resistance is directly related to what? Obesity. And here's the deal with that. Abdominal fat, not necessarily fat everywhere else, but that abdominal fat chemically works against insulin. It makes our cells not respond to insulin. So the more abdominal fat you have, the more likely you are to be insulin resistant. So if you are insulin resistant and you can decrease your abdominal fat, then chances are you can decrease the severity of your diabetes, or in some cases, you can become non-diabetic. And so type 2 almost always involves insulin resistance that may or may not be combined with a decreased insulin production by the pancreas. So what can you say is the very major difference between type 1 and type 2?
Type 1, you just don't make the insulin, and type 2, your body doesn't know what to do with it.
Also, that one is you cannot prevent and one you can.
Okay. I'll go with that. You can't prevent type 1, but you can prevent type 2. The major difference, what I want you to get out of this, is that in type 1, no insulin is produced. So there is no insulin. So the only way that patient can survive is to have insulin replacement. So the only way they can live is with insulin shots. Now, there's some stuff going on with pancreatic transplants and stuff like that. That's not common. So we're just not gonna get into that because I want you to just know basic diabetes. All right. At least in type 2, there's some insulin produced. And because there's some insulin produced, that keeps us from getting into major problems with diabetes-related acidosis and the critical care syndromes that come from diabetes. And then we have, let's talk about gestational. Diabetes mellitus. So gestational diabetes mellitus is during pregnancy, obviously. And it's very similar to type 2. In type 2, abdominal fat causes chemical resistance by the cells. In gestational diabetes, placental hormones are what cause the problem. So those placental hormones cause insulin resistance. Now, most of the time, that's going to occur at 25 to 28 weeks gestation. So it doesn't usually start out that way. But around 25 to 28 weeks, the placenta is large enough to produce enough hormones that it would cause insulin resistance. Now, we might see that earlier with a large for age baby or a pregnancy that has multiple placentas like twins or triplets or whatever. Because then you would have more placental hormones, and so mom might become more gestational early on because of more hormones. So normally they test moms with a glucose tolerance test around 28 weeks to see if they have insulin resistance. So that's just going to introduce you to that. You'll learn more about that in OB next semester. And then the last type that we're going to talk about is called secondary or iatrogenic diabetes. What does the term iatrogenic mean?
I'm gonna guess caused by something else.
Treatment.
Okay.
Another medical condition.
Yeah, doesn't it stem off of another medical condition that you previously or currently have?
Or the treatment of that condition?
The treatment, there you go, the treatment of that condition. So iatrogenic, you can basically replace that word with medically induced. So some kind of treatment that has been prescribed for the patient is what causes an iatrogenic problem. And it might not be just diabetes. You can have iatrogenic neutropenia or a whole host of other different medical conditions. But iatrogenic diabetes is fairly common because the drugs that usually cause this are steroids, and we see a lot of steroids being used. Iatrogenic also means that when the treatment is stopped, the diabetes goes away. So we're going to put caused by medical treatment. And then we're going to put steroids. Now, are there other things? Absolutely. But the steroids are what's most common. And those patients, a lot of times you may see a patient in the hospital who's getting insulin and they're not diabetic. So the first thing that you want to do is to look and see if they're on steroids. Because sometimes if they are on steroids, we'll have to put insulin into their care plan to make sure that we maintain their blood sugars. On my particular unit, we have patients that are there for heart surgeries. And they don't heal well if their blood sugar is high. Because remember that high blood sugar damages microvasculature. Well, what do we need to heal incisions? We need blood supply through the microvasculature. So they always want to make sure that our patients have normal blood sugars so that they can heal. So we'll put them on what we call a glucose stabilizer. And what that does is it's an insulin regimen that we give when their blood sugar gets out of range, just to keep it down in the lower ranges so that they'll heal better. So you may see insulin given for reasons other than diabetes. All right, we've already talked about that. Okay, so let's talk about our patient. She's going to go home with metformin by mouth, 1,000 milligrams daily. She's going to go home with diabetic education, and she's going to go home with glucometer strips, lancets, a 30-day supply, and an order for 60 grams of carbohydrates per meal. So, what does she need to know about her metformin? Metformin.
You can take it with alcohol.
Okay, you shouldn't take it with alcohol. Metformin is
It also causes stomach upset.
Yes, it does. Now, metformin is the #1 choice for oral anti-diabetic medication. That's what you see more physicians ordering is metformin. But you have to be careful with compliance with metformin. It's not a fun drug to take, especially initially. Once your body gets used to it, it's not so bad. But in the beginning, it causes a lot of GI distress. So it causes diarrhea, it causes abdominal pain and bloating. And a lot of people are just like, I can't take it. And so for them, we may have to find something else. But metformin being the first line choice is beneficial without insulin and works well by itself. What else do we need to teach our patients about metformin?
Don't take other kidney toxic drugs.
Okay, don't take with other kidney toxic drugs. So we want them to be careful with things like non-steroidals, NSAIDs. They have to be real careful with anything that would damage their kidneys. Now, for us as healthcare workers, there's a major contraindication to the use of metformin. What is it?
IV contrast.
Yes, your IV contrast dye. Absolutely. So your IV contrast dye is very toxic to the kidneys. And metformin is toxic to the kidneys. And when you give them together, the risk of renal damage is pretty high. In fact, you can find cases where a patient who was on metformin got IV contrast dye and wound up being dialysis dependent for the rest of their lives. So this isn't something we can play around with. It's very serious. So one of the things that you'll need to know for me and for NCLEX for sure is that when a patient who is on metformin needs those contrast mediums that are given IV. Now, this doesn't mean the ones that they swallow, but the ones that go IV. If they receive one that goes IV, we have to hold that metformin for 2 days, for 48 hours after they get the dye. So let's say that a patient gets their metformin at 9 o'clock at night. At 9 o'clock the next morning, they go for a CAT scan and they have IV contrast dye. They're not going to get their nighttime metformin, or any metformin for that matter, for 48 hours after the test. Because we can't mix metformin with those dyes.
Seems like IV contrast dye does more harm than it does good.
It can in certain patients. Now, there is and this is kind of off topic, but we can give acetylcysteine, which is the same thing as Mucomyst. It can be used as a mucolytic, as a nebulizer, or it can be given orally. If you give it orally as Mucomyst or as acetylcysteine, it does two things. It protects the kidneys, and it also is an antidote for acetaminophen poisoning. So we use it for other things, but like my dad only has one kidney. He had kidney cancer and had one of his kidneys removed. But he had to have an echocardiogram, and he had to have a cardiac cath with dye. and they felt like it was more important to do the cath, even though his renal system is shot. So what they did was they gave him the dye, and then they gave him acetylcysteine afterward to drink, which was supposed to help protect his kidneys. So occasionally you might see something wacky done to prevent a problem with metformin and CAT scan dye. But for the most part, the protocol that you need to remember is that you have to hold that metformin for 48 hours after any contrast dye. All right. So 3 months from today, this patient comes back and these are her labs. So the labs on the right are from today. I'm sorry. The labs on the left are for today, and the labs on the right are what she's going to have 3 months in the future. What do you think about her labs?
She's lost another 30 pounds.
Okay.
They all look a lot better.
Okay. And she's lost a total of 30 pounds, but in 3 months, she's lost, what, 16 pounds? 16 pounds in 3 months, is that acceptable?
Healthy.
Yes.
Okay.
I mean, I guess it is.
Well, we say 1 to 2 pounds a week. So in 3 months, that would be 12 to 13 weeks. What do you think we can attribute that weight loss to?
Her diet being better and probably getting in a little more exercise from the teachings from her previous visit.
Okay. We would like to think that she's exercising more.
And the metformin.
Yes. So exercise, and she's managing her diet better, and the metformin is lowering her blood sugar, so she's not storing as much as fat. What else about the metformin? What do you think that metformin is doing to her appetite?
Decrease.
Yeah. It's going to decrease her appetite. And so by decreasing her appetite, by decreasing her blood sugar, and by her being compliant with her treatment, then yes, she's going to lose weight. How is that helpful to her?
When she decreases her weight or her waist circumference, it's probably gonna help her be less insulin resistant.
Yeah, because she's losing abdominal fat. So what could we do? What would be an easy assessment to relate that?
The BMI.
Okay. We could look for the BMI. What else could we do?
Could you do that another AC1 test?
We could do an A1C.
A1C.
We could do body fat composition. Which is more reliable, your BMI or your body fat composition?
Body fat composition.
Why?
Because the BMI doesn't take into account like the body shape or things like that.
Muscle.
Muscle. Yeah.
Okay. Absolutely. So we could look at her body mass composition, and we could also just measure her waist circumference. So there's a lot of things that we could do, but basically, in a nutshell, when we look over the last 3 months since she started her therapy, we can tell that she's gotten improvement. So do you think we'd want to change her medicine, or do you think we want to leave it as is?
Leave it as.
Yeah, I think we want to leave it right where it is and just check her in another 3 months. And in another 3 months, when we get her A1C, it'll be much more reliable than it is right now. Because she's had more time to make more red blood cells since she's changed her diet, her activity level, and her medication. All right, so what other kind of diabetic teaching does she need? Go back and look at her prescription for her diet.
How to use the glucometer.
Okay. How to use how to check her blood sugar and what to do about it when it's too high or too low.
How to count carbs and
How to
portions.
count carbs. Okay. Counting carbs is important. Now, there are lots of different ways. There's a diabetic exchange diet, which is kind of what I use, along with counting carbs. Counting carbs doesn't necessarily work if a patient is really not able to do simple math. But most patients can do a fair amount of carb counting. The great thing about it now is that we have all these home delivery programs that deliver meals to your door. And so for some patients who can afford it, they can have their meals delivered and they'll already be appropriate for their diet. Truthfully, y'all, diabetic meal planning is not that big of a deal as long as we do a great job of teaching patients. Now, what would you think if you became ill today and you went to the physician and got worked up and he said, I hate to tell you this, but you have type 2 diabetes? What would you, how would you react?
I'd be upset, but I would understand and try to fix it.
Okay.
I would ask
Straight to the
what
gym.
kind of lifestyle changes are needing to be done to help this or fix it.
Okay.
I'd personally be in denial.
I'd probably be right there with you.
I would have went straight to the gym right after the doctor's appointment.
Okay. How many of you would be just devastated because you couldn't eat what you wanted to eat?
Oh yeah, me.
Oh yeah.
Devastated, but I'd understand the reason
Definitely
why.
want to eat my sweets.
Okay. Well, that's exactly how your patients are going to feel. They're going to feel like they're going to be deprived of everything that they want. And that is the one thing that we as healthcare providers have to work to prevent them feeling that way. Now, obviously, this is going to depend on the severity of diabetes. But with appropriate meal planning, most patients can eat what they want. Now, that doesn't mean that they can eat everything they want. And that doesn't mean that they can eat as much of everything that they want.
So we need to teach moderation.
And good choices. So, I guess because I'm a healthcare worker And because I'm one of those people that I'm going to find a shortcut, I'm going to find a better way to do something. That's just the way I'm programmed. I'm a fixer. I can very easily figure out how to work something that I want into my diet and still keep my A1C where it belongs. And that's what we have to teach our patients to do. Now, it's not fun at first because at first there's a lot involved. And what I mean by that is you got to keep a food journal, because that food journal is going to help you determine what you can eat and what you can't. And what I mean by that is not every diabetic reacts the same way to the same carbs. And so you have to find out what kind of carbs you tolerate better than others. And so journaling is the perfect way to do that. So what I did when I was pregnant the first time and had diabetes was I would eat my meals, and this is what I went to an endocrinologist, and this is what he taught me to do. And I still use that information today. So I got me a notebook. I ate my meals conservatively, following my diet plan. 2 hours after every meal, I would take my blood sugar. And when my blood sugar was abnormal, I would write down what I had eaten so that I could figure out a trend. And I would know, okay, if you eat this, then your blood sugar is going to be too high. And what I found was that as long as I ate some lean meat or some protein with my meals, rice and pasta really didn't affect me that much. What is the purpose of eating fat and protein with your meals, with your carbs?
So proteins be for muscle mass?
Protein to fill you up.
They are, but protein digests more slowly than carbohydrates do. And so they slow down digestion. And so if you add proteins and fats, moderately fats, into your diet as a diabetic, what happens is that it slows down your digestion and keeps your blood sugar from going up so fast. So that's why our diabetics should be taught to add in appropriate amounts of healthy fats and proteins to help with that. What I found out also was that it didn't matter what I ate with it. If I ate potatoes, my blood sugar was going sky high. Potatoes were the thing that just made my blood sugar go crazy. And so I really had to learn to watch potatoes. Not that I didn't watch everything else, but the potatoes, I knew that if I ate them, I was going to be battling with my blood sugar. So now, years later, I know that if I eat potatoes, I have to be very careful with how much I eat. And along with that, we also have to teach our diabetics that you can eat basically any kind of carb you want if you are conservative with it and if you make choices for which carbs you can have. I am a bread addict. I would rather have a piece of bread and butter than a piece of cake. So I know that if I want to go somewhere where they have good bread to eat, that it would be better for me to get my protein and my meat, a side like asparagus or green beans or a salad and bread instead of a starch like baked potato and bread. So I have to decide which carbs am I going to reward myself with today and put those in my diet to satisfy me without eating a bunch of other carbs that I really don't want. I don't waste my calories on carbohydrates. And so if I want ice cream, I can have ice cream. I can't have a whole pint of ice cream, but I could have a couple of scoops of ice cream, but I might just leave off a roll. So what you do is you determine which type of carb you want with your meal, and then you alter the rest of your carbs around it. And when you teach patients that way, they do better with understanding the management and they don't feel so deficient in what they want. It's easier for them to say, okay, I get this now. I can have carbs. I just have to choose which ones I'd rather have today. So today it might be, I really want a baked potato. But tomorrow it might be, ooh, it's my daughter's birthday and I want birthday cake. So I'm going to have a healthy salad and then birthday cake. And I think so many times, especially physicians, fail to help patients understand that this doesn't mean that you can't ever have anything that you want to eat. You just have to plan ahead. And so to teach this lady then, we want to teach her about her 60 grams of carbs. So in diabetes, all of your carbohydrates are basically split up into 15 gram units. So how many units of carbs can our patient have?
She can have 4 units.
Okay, so she can have 4 units or four carbohydrates. So 15 grams of carbohydrate is equivalent to a half a cup pasta, rice, potatoes, corn, fruit, non-sugared fruit, like fresh fruit with no added sugar. So if the patient could have a 60-gram carbohydrate meal, what do you want to give her? As an example of a meal plan. Well, let's give her a hamburger and fries. So 15 grams is also 1 piece of bread. So how are we gonna give her fries and a bread, and a burger to equal 60 grams?
So she could have one burger because it's got 2 buns or top and bottom, so that's 30. And then she could have 1 cup of fries because that's 30.
Okay. Now, you are correct. That is a 60-gram meal. But what do we also have to take into consideration?
Like ketchup, toppings and stuff. Or how it's.
What'd you say?
I was thinking like, I mean, French fries are going to be fried either way, but I don't know if that like fried or baked would have anything to do with it. Like
Not going to change
potatoes.
the carb content. It's going to make it healthier, but it's not going to change the carb content. So
They
you
might
have
throw
given
on cheese or chili or some other toppings might mess up the carb
Okay.
count.
Okay. So what about your condiments?
Mustard.
We have mustard, which doesn't have a lot of sugar.
Ketchup
Mayo,
has a lot of sugar.
ketchup has a lot of sugar. So what if she's going to have ketchup on her fries and on her burger?
So then she probably needs to cut back on 1 unit or a half a cup of those fries.
She could also
Exactly.
do no bun. She could just eat the burger
Okay.
without the bun.
Or she could set it on the bottom of the bun and eat it like that.
Yeah.
Absolutely. So she could choose, well, I really want French fries today. And I can't eat my French fries without ketchup. So I'm just going to do away with the bun. Or I'm going to eat half the bun so that I can still have all the fries. There are lots of different ways she could do it to make herself happy and satisfied with her meal. But what people do is they don't think about those condiments. They count. And so we have to go back and add in sources of all carbohydrates. And that's also assuming what? That she's going to drink a sugar-free beverage. Because if she has sweet tea, guess what? Her fries are gone. Can't have it all. Now, 60 is a good diabetic diet in the hospital. Most of the time they order like 75 grams, which to me is just an ungodly amount of carbohydrate. I never eat 75 grams carbs in a meal. It's just a lot. Well, I won't say never. There are a couple of exceptions. Tell me about the last time you had pizza or spaghetti. How many carbs do you think you ate?
Too many.
More than a week's worth.
Way
Who
more
can
than
eat a half a cup of noodles with their spaghetti? That's ridiculous. Most adults usually eat about 2 cups. So that right there, just not the sauce, but just the noodles would be your 60-gram diet. So then you have to add in all the tomato sauce and the sugar and the tomatoes for the whatever kind of sauce you put on your spaghetti. And then you have to think about if you have garlic bread or whatever else you happen to be adding in. So you have to really think about not just what you eat, but how much you eat. So any questions about diet planning?
I saw on a different resource I was trying to read before class, and it talked about how you could teach to do several small meals throughout the day. Is that
Yes.
for just like type 1, or would that be for type 2 as well?
It can be for both. And in fact, when I first became a nurse, and probably up until about maybe 10 years ago or so, in the hospital, they would bring the 3 meals a day, but then they would also get 2 snacks. They would bring them a snack between lunch and dinner, like an apple or something, peanut butter and crackers, something like that. And then they would always bring the diabetics who were on a diabetic diet a half of a ham sandwich or a turkey sandwich at 9 o'clock at night for them to eat before they went to bed. Now, the reason for that was back then we had to use an insulin that didn't really jive with the body's natural flow of insulin production. And so what happened was they would bottom out in the middle of the night, or they would bottom out in the afternoon. And so we would have to give them a source of glucose to keep them from becoming hypoglycemic. Luckily, most physicians don't use that insulin anymore, and we're going to talk about that in a little bit. But that kept them from becoming hypoglycemic. We don't have to worry about that so much anymore because, as I said, that type of insulin just isn't used as much as it used to be, which is a great thing as far as I'm concerned because I can't stand it. I think it's a terrible way to treat diabetes. So that was part of the reason why we would give them snacks during the day. Now, other than that, we do it just to kind of spread their calories out so that they're not raising their blood sugar up so much at one time. So there's a couple different reasons for doing that. But yeah, 6 small meals a day, 5 small meals a day is great for a diabetic. It helps to regulate their sugar more. Now, you might be asked to choose foods that would make up a certain carbohydrate diet, or you might be asked to pick out which plate of food would be equivalent to a certain carb diet. So you need to understand counting carbs. So if we went back to our spaghetti, if we had 1 cup of spaghetti with meat sauce, we had a piece of garlic bread, and a half a cup of canned peaches. Approximately how many carbs would that be?
60.
Okay. So you would have 30 grams of carbs in your pasta, 15 grams of carbs in your garlic toast, and 15 grams of carbs in the fruit. What's the problem with that?
It's not including the sauce.
It's not including the sauce. So if we added in the sauce, we could estimate that a half a cup would have approximately how many carbs?
15.
15, because it's mostly tomatoes. So, we know that this isn't going to be an exact science. You're not going to pull out your book every time you go to a restaurant, but we can guesstimate it. So we could say a half a cup of sauce, a cup of noodles, a piece of garlic bread, and a half a cup of peaches or pears or whatever. That's going to be about 75 grams, which is a good, healthy diabetic diet. So, what about a turkey sandwich and an apple? How many carbs is that?
45.
45. Plus what?
Condiments.
Okay, plus condiments. Let's just say there was a little mustard and a piece of provolone cheese. Cheese is going to have a little bit. What could we do then if she's at 45 if we wanted her to be at 60?
Give her a piece of fruit.
Okay.
Offer her a different drink other than water or unsweetened tea.
Okay. So she could probably have maybe a bag of chips, or a single chocolate chip cookie. So y'all get the idea of how you're going to do that. So you got to think about your basic unit of measure is that 15 grams of carbohydrate. Everything is figured off of 15 grams. So that's why you usually have 45-gram diet, 60-gram diet, 75-gram diet. And it's talking about on the plate, that's the number of carbs that you can see. Now, what if your patient's in the hospital and they get their meal and they're like, this just didn't taste that great. I'm really not pleased with it. Could I just have some ice cream? Is that okay?
Every now and again.
Okay. What would we have to know?
How much they ate of their meal before giving them ice cream?
And how much ice cream they could have. Exactly. So a little cup in the hospital is going to be like 15. And so if they really didn't eat anything but their garlic bread and their peaches, and they didn't eat their spaghetti, they could certainly have some ice cream. We just have to be careful when people ask for stuff or their families go get stuff for them, that it's not going over their caloric or their carb content. And one of the things that will throw people over their content really quick are their beverages. So people will ask you for juice, and if somebody doesn't look at their diet and see that they're diabetic and they start giving them juice, their sugar's going to be sky high. So we just have to be really careful with teaching them you can't drink a whole bunch of juice. That's
Good
one thing
job.
I really miss. I never thought I'd miss juice, but juice is very sugary. So if I have any, I usually will limit myself to 4 ounces, and even then, that's a kind of a treat. Is there a comment?
It's kind of related. Just in the ER, having patients that are NPO, I've had EMS come in and give them something that, like, grab them a water or a ginger ale or something, even though they're NPO and it's not their patient. And then, yeah. And
Yeah.
people don't understand NPO like that.
Right. And so, a lot of times people are trying to help, but if they're not looking at their diet, they can actually do more harm than good. So when you're in the hospitals and your clinicals now, if somebody stops you and says, "Hey man, can you bring me some orange juice?" Go look at their diet first or ask their nurse before you just give it to them, because you don't want their sugar to be out of whack. All right, so that's diet planning. What else do we need to teach our patient?
Exercise and activity levels.
Okay. We want them doing exercise about 3 days a week minimum. What else?
How to use the lancet and how to prick your finger like at an angle.
Okay. Where to prick it? We don't want them pricking it on the finger pad. We want them
side of it.
to.
On the
Yeah,
side
we
of the
want
finger.
them. Yep, on the side. What else?
Like signs and symptoms of like low and high blood sugar.
Okay. Definitely the signs and symptoms of hyper and hypoglycemia. They need to have a food source. Now, that brings up an interesting question.
They need to have like a never mind.
Go ahead.
Oh, I was gonna say they probably need to have like an emergency supply of like hard candies or something to kind of, if they have if the sugar drops really low.
Okay. So, how would you know what was safe?
What do you mean what was safe? Like what would you take that's safe
Yeah.
for you to take? So like your
Is that
signs of
Simone? Who's that talking?
oh, this is Simone.
I thought it was. Okay, Simone, pick your poison. What you want them to have?
Oh, a piece of candy, peppermint maybe.
Okay. So we're gonna say candy. And we're talking about sugary candy. Hard candy. So like cinnamon disc, butterscotch, lifesavers, peppermints, that kind. So we want to give them how much when they're hypoglycemic?
Just one.
Well, with hypoglycemia, we're looking for a fast 15.
Would it not be better to use like orange juice or like soda because it's faster to hit the bloodstream?
Or maybe
Well,
milk.
it might be, but the liquids aren't always as portable and as non-perishable. So let's go through all of these and talk about them. So how many pieces of hard candy or lifesavers would it take to give us a fast 15?
3 maybe?
I don't know, 3, yeah.
1?
About 5. So 5 lifesavers. 5 5 pieces of peppermint. We just teach the patients to remember 5 for 15. All
Don't
right.
they sell glucagon as well?
Yeah. You can. What about orange juice?
Would it be about a cup?
4 ounces?
Yeah, like 1 cup.
How much is a cup?
8 ounces.
240.
4
8
ounces.
ounces. How many carbs are in 8 ounces of orange juice?
30.
30.
30. So we're going to go with that 4 ounces that you were talking about. All right. What else can we give them? Why do we call it the fast 15?
That shoots it up immediately.
Right. It doesn't really require any breakdown to be absorbed. It's absorbed very quickly. Now, if somebody said glucagon, we could give them glucagon.
I know that Walmart sells glucagon as well. So usually, don't they usually carry it on them, or is that just?
They can. But now, how do you give glucagon?
Well, it depends on which one you get. There's like an oral one that you put in their mouth, like on the side or like under the tongue, and then there's the tablets. There's like a gel in the tablet.
Well, you've got
at least in
glucose
Walmart.
tabs.
That's glucose tab. Glucagon is IM.
Oh, excuse me, glucose tabs. My bad.
Yeah, so we would give them the glucose tabs, and y'all, those are 4 grams each. So just to be safe, I would give how many?
4.
4 tabs.
4?
4.
Yeah. What about cola?
Would that be
Most
4
sources-
ounces as well?
Most sources say 5 ounces. I think that 4 to 5 ounces would be fine. But 8 ounces would be too much. And then a real quick and easy thing for them to do that they can keep with them all the time is 1 little tube of that cake gel.
The whole tube?
Well, the small tube.
Yeah, like I know what you're talking about. Like you get the whole thing.
Yeah.
Instead of just like
No, it's the small tube is only like a mouthful. Now, they can get a larger tube and just kind of fill their mouthful with it and keep a larger tube. But basically, if you think about cake frosting that's in the squeeze tube that you can just carry around like a tube of toothpaste, a mouthful is about 15 grams.
I want to say it was either Maine or Vermont EMS, state EMS passed their medical control and switched from oral glucose to a tube of maple syrup.
Yeah. And in fact, when I was looking at some of this stuff last night, one of the tables that I found for the Fast 15 did say something about brown sugar or syrup. And I want to say it was a tablespoon. But what would be the purpose for that?
It's a simple form of sugar. It doesn't take very long to metabolize.
Yeah, I mean, it goes straight in. It's already a liquid. It's cheap. It lasts forever. And so, yeah, that would be something great to have around. And, you know, on your ambulance, you wouldn't have to worry about it going out of date as much. And it's not regulated. So it would just be very easy. And you can teach your patients to do it too. I mean, most people have syrup around very easy. So that's interesting, especially after I just read something about syrup last night. I'd never really thought about syrup. Okay, so that's our Fast 15. So you need to know what you would give a patient. Now, let's go back to this orange juice for a quick minute. Notice that that doesn't say orange juice with sugar poured in it, which is the old-fashioned way of doing it. I've seen nurses put a whole ton of sugar in orange juice and mix it up and give it to somebody. That sugar is not necessary. Now, what characteristic of a patient do we have to be able to do this Fast 15?
Their blood glucose is less than 70.
Have to be alert.
Okay, so blood glucose less than 70, and they have to be alert and able to swallow. If they're not, we can put glucose gel in their buccal area in their mouth, or we can give them glucagon, which what does the glucagon do? It causes a release of glucose from the liver to bring up their glucose level. And then if all else fails, we're going to put an IV in and we can give them 50% dextrose. Y'all, that stuff is like Karo syrup. It is thick and sugary, and it will tear their veins up if you have to do it very often. Because our veins don't like that concentrated sugar, but it will get the blood sugar up quickly. So if you have to get it up quickly, then that's a good choice. And that's what we use in the hospital a lot. So that's how to manage hypoglycemia. All right, the last thing I want to talk about before we start talking about insulin is foot care. Well, and sick day rules. We need to talk about foot care and sick day rules. With foot care, we don't want their foot to look like this. Okay, this is actually a picture of a diabetic ulcer. And they usually occur in this area of the foot. Now, we're going to talk about arterial ulcers and venous ulcers a little bit later in the semester, and you'll have to kind of know the difference between them and diabetic foot ulcers. What else do you notice about this foot?
It's cracking. The skin.
Okay, it's cracking.
It's an open wound.
Okay, got
It
an
looks
open wound.
Doesn't
looks-
look like it's healing.
It looks dry, like it's not healing, like it doesn't have any blood source or any
Okay.
related tissue.
It looks
Okay.
swollen.
It's peeling.
All right. What do you think about this person's hygiene?
They don't wash they don't take care of their feet.
Yeah, their foot hygiene is kind of lacking.
Mm-hmm.
This could be the beginning that would lead us to a lower extremity amputation. Because these wounds, when they can't heal, they get bigger and they get infected and things happen, and eventually we may have to have an amputation. So we want to prevent this. So you see all this crud in the toes? They need to make sure that they're cleaning in between their toes. They don't want to put oil-based lotions or powders on their feet, because oil-based lotions and powders are going to trap bacteria and provide a medium for bacterial growth in and around those toes. So we want them to cut their toes off straight, like you see here, right here. They should be straight. They really shouldn't be rounded. They need to be short, and they need to clean out all the crud under the nail and around the nail. Keep it all clean so that they don't get any bacteria in it. They should report any kind of injury to their foot and let their physician look at it to make sure that it heals. One thing that you cannot do in the hospital without a doctor's order is trim toenails, but you can ask for a referral to a podiatrist. If their toes are in bad shape, we can get a podiatrist to come in and get them in shape. But foot care is really important. The number one reason for lower extremity amputations in the United States is diabetes. So we want them to provide good foot care. And remember that a lot of diabetic patients have trouble with sensation in their feet due to peripheral neuropathy. And so what we need to remember is teach them not to just get in a tub of hot water because they can burn their feet and they won't ever feel it. To wear shoes that fit. I used to teach to make sure that they had a professional fit them for shoes. You know, when I was a little girl, and probably some of you too, when you went to the shoe store, there was always somebody there that would fit you for your size and then help you look to find the appropriate shoe. You don't see that anymore. Matter of fact, it's really not all that common to see a shoe store. I mean, now you see shoes in department stores and Walmart and everywhere else, and not necessarily, you don't just have to go to a shoe store to get shoes. And when people fit themselves, if they can't feel how well the shoe fits, then they may wind up with blisters or other irritation and stuff that would be the start of a major problem with their foot. We also want them to wear cotton socks that help prevent bacterial infection and all those kind of things. Now let's talk about sick day rules. When people have diabetes and they get sick, even if they aren't eating, what happens to their blood sugar?
It still goes up.
Goes up. Still goes up.
And what causes it to go up?
The immune response from being sick?
Yes, the stress response. So the stress response stimulates cortisol. And cortisol regulates your blood sugar. So as your stress goes up, cortisol goes up and blood sugar goes up. And so we wind up with people that even though they might not be eating, they're going to have some major issues with hyperglycemia. So in order to combat that, we teach them sick day rules. And so the sick day rules are pretty standard from place to place. So the first thing is take your meds. Don't skip your insulin. Don't skip your metformin or whatever it is you take. If you're sick, you still have to take your meds. Okay? Then how often do most diabetics who are serious diabetics, meaning that their sugar is not stable, how often do they have to take their blood sugars?
3 to 4 times a day.
Hours.
At least 4 times a
Okay,
day.
used to be 4 times a day. So now we're going to say check your blood glucose level every 3 to 4 hours. So instead of doing it every 6, now we're going to do it every 3 to 4. And the way that we're going to keep them from becoming hyper or hypoglycemic is to adjust your carb intake to your blood glucose level. Meaning, if you're increased PGL, then you're going to have less carbs. If you're decreased PGL, you're going to increase your carbs to keep your blood sugar normal. And then if you're unable to ingest carbs for more than 6 hours, then you need to call your healthcare provider. Okay? So when they're sick, they will wind up in the hospital, especially a type 1. Good Lord, they get sick so quick. And they come in, if they even make it to the hospital without going into DKA, they come in and they're just sick people. Blood sugars are sky high. Some of them are comatose. I've seen patients who have, they either live by themselves or they were home alone and they became hyperglycemic and went into a hyperglycemic coma. And I've seen patients that have been there for 2 or 3 days until somebody decided to do a welfare check on them and found them in the floor in a diabetic coma.
It's very common. I ran a
Oh,
lot
yeah.
of DOAs that were from uncontrolled hyperglycemia.
Yeah.
When I was 4, I was taught, because my mom's a type 1, how to do glucagon because it was just me and her.
Yeah. Yeah. I mean, it's something that you have to manage, because if you don't, you're not going to live very long. And we see our patients with these hyperglycemic crises or diabetic ketoacidosis. We see it a lot in younger people, young adults, late teens. Type 1 diabetes occurs, I think the average age is like 4, maybe. And so these kids that have had type 1, they've had it pretty much their whole lives, and mom and dad have helped to manage it. So they go off to college or they get in high school and want to go hang with their friends. They want to eat pizza and spaghetti and, hang out, have burgers and fries and whatever. And a lot of them will think, all my life they've told me I have this diabetes, but I feel great. I don't think there's anything wrong with me. I'm going to just try it out. Or they go to college and do what most college kids do, drink beer and eat pizza, and it just messes with their sugars, and they wind up in a hyperglycemic state, and they will come in. I saw one guy that had laid in the floor 3 or 4 days before his family finally went and checked on him, and he wound up being paralyzed from the waist down from rhabdomyolysis, where his diabetes had damaged his muscles so badly that he became paralyzed. So, I mean, it causes a lot of problems. So, teaching these patients to manage this is really important. So, that's our sick day rules. All right, so let's look at some insulin. I'm going to go back. I think it's on your D2L site.
With the sick day rules, is there a rule about when you call the PCP about the blood sugar being over, I think 300? If you check it twice, then you call your PCP. It was one of the questions on the HESI quiz.
Are you talking about for a patient or for a healthcare provider?
For like if a patient's at home for a sick day, is there a rule about if they check their blood glucose level and it's over 300, 2 times in a row, would they then want to call the doctor too?
Absolutely.
Okay.
Because at 300, they're going to start excreting sugar in their urine, which is going to be more damaging to their kidneys. And so if they can't get it down after 2 consecutive draws, then yeah, they need to call their PCP. All right, so I put on here somewhere. Here we go, this document right here. This document is the most important one for you as far as the meds. Okay. So very important. The goal of insulin therapy is to mimic the normal pancreatic secretion of insulin. So when somebody...
Do you mind saying that one more time so I can write it down?
Yeah. Can you see the screen?
Okay, I didn't
Do
see
you
it on
see
there.
the-
I'm sorry.
You see the wavelength?
Yes, ma'am.
Okay, so it's, I wasn't sure if my screen sharing followed me over there. Okay, so it's in red. And the goal of insulin therapy is to mimic normal pancreatic secretion of insulin. If you understand that principle right there, then it becomes so much easier to understand which kind of insulins are used for which kind of treatment. So, when you look, your insulin secretion and your glucose intake are going to kind of mirror each other, right? Because the more glucose you take in, the more insulin your body has to secrete. So this little chart right here kind of shows you what the normal person does over the period of 24 hours as far as insulin secretion. So we have a baseline, and if you look, it kind of runs just at the top of these black lines. You kind of have a baseline. Now, question for you. Do you need insulin when you're asleep?
Yes.
Okay, why?
Because your body's still producing sugar even though we're asleep.
Okay. And what does insulin do with sugar?
Insulin helps the sugar get into the cells to have energy.
Okay, absolutely. So if we are going to breathe at night and digest at night and have our heartbeat at night and all of that, then we have to have energy to do it. And so our cells get that energy when insulin opens cells up and blood sugar goes into the cells for energy. So our pancreas secretes a small amount of insulin all the time. And it's going to run right here along this baseline. Okay. And then when we eat, as our blood sugar goes up, our insulin level goes up, and then it brings that blood sugar back down to our baseline or thereabouts. So every time we eat, we produce a little bit more insulin. And it goes up and down like that. So our goal when we have to replace insulin is to make it look like this right here. All right, so now you know what the goal is. So we're going to figure out how we're going to get there. All right, so these are your different types of insulin. So you have aspart, lispro, and glulicine, which are rapid acting. So see, they act almost immediately. And then they've done their thing within 4 hours and they're gone. Regular insulin is a little bit longer acting than rapid. It's considered a short acting insulin. And it takes it a little bit longer to work, but it still does its thing, and then it's usually metabolized out of the system within 8 hours. Now, NPH is the one that I said that I absolutely despise because it in no way mimics anything that our pancreas does. And if you look at it, it peaks. If you give it in the morning, it peaks between lunch and supper when the patient's blood sugar is already low, predisposing them to hypoglycemia. If you give it at night, it peaks in the middle of the night while the patient's asleep. And again, it makes them hypoglycemic because it doesn't mimic normal pancreatic secretion of insulin. And when I graduated from school, the only thing we really had was regular and NPH. We didn't have all these other types of insulin. Those are relatively new. And we would have patients be in hypo and hyperglycemia all the time because that was what we had to use, and NPH just doesn't work with a peak onset and duration that mimics the normal pancreas. So we don't see it used very often anymore. Thank goodness. They've decided to treat diabetes a lot differently. Now, if you have a patient that's been on it forever and ever, and they like the NPH, you might see it. Or if you have an old doctor that really likes it, you might see it. But we just don't use a lot of NPH. And then the Detamir, I'm going to ask you to think about it more like the Glargine, more like a straight line. Because your Detamir and your Glargine are long-acting. They are considered basal insulins, which means they don't have any peak. So those basal insulins are what are going to mimic this basal line, this imaginary line that runs right through here. So that's what your pancreas is going to secrete all the time, whether you're awake or whether you're sleeping. So Detamir and Glargine are going to replace those. Okay. Now, this next picture is kind of the same thing, but it shows the insulins superimposed on the normal function so that you can see how it gets replaced appropriately. So the blue line is our normal pancreatic secretion. The orange is basal insulin that is either glargine or detamere. And then the the green here, that's your bolus insulin. So we have bolus and we have basal. Basal is long acting with no peak, and bolus peaks within 2 hours and then comes down just like your normal pancreas would. So we're going to use rapid acting Lispro, Aspart, or glulisine here with meals only to take care of the meals. And then we're going to use glargine or detamere once a day to run underneath that to provide the basal. So it's very common for patients to be getting at least 2 types of insulin. Does this make sense? Do you have any questions about it?
How would metformin fall into this?
Metformin is actually just going to increase insulin from the pancreas in a type 2 diabetic. And it may play a role in stimulating the cells to respond to insulin to open up to let blood glucose in. But it's known mainly for helping the pancreas to secrete more insulin.
Where is regular insulin on this graph?
Regular insulin, if you look at it, you see how it comes further down here? We can use it, but if we go back to our schematic right here, your regular, if we give it here, it's not going to peak until over here somewhere. So it broadens this curve right here. So it's not as good at mimicking the normal pancreas, but it does work well. And some people use regular to manage their meals or if their blood sugar gets high. We do still see a fair amount of regular insulin, but I will tell you that most practitioners have gone to what you see right here, where they're just using rapid before meals and when the blood sugar is high, and basal insulin just to keep that basal rate all the time. Now, I've given you something to study here where it talks about the different types of insulin. So that's just something really quick and dirty for you to study so that you know the insulin. So you need to know how they act and what they might be used for. But this shows you exactly how they're used, and this shows you how they act.
For a question, would this type of insulin therapy be used mainly with type 1 diabetics versus type 2, or is it the same kind of for both?
It definitely is going to be used for type 1 no matter what, unless they're on a pump. Type 2, however, did I say type 2 or 1? Type 1 is what we were just talking about.
How
Now,
does the
type
pump
type 2 is a little bit trickier in that some people will take insulin like that if their pancreas just doesn't work well, if they have alcoholism or pancreatic cancer or they're just advanced age. But for some patients with type 2, we might just use just a bolus just with meals or when their blood sugar gets high.
How do combination insulin fall in there then?
You mean like your 70-30 mix?
Like Humalog, 50-50 and
Yeah. Let's see. Those are a mixture in a bottle. Again, I'm not a fan, but when you look down here where it says pre-mixed, a combination, what they do is they take NPH, which is this intermediate acting, and they mix it usually with regular. And so like your Humulin 50-50 would be 50% NPH and 50% regular. The problem is when you put two drugs in one dose and you can't separate them, you can't customize it. And so it makes it a little bit harder to manage the blood sugar. So if you go back here and look, if you're mixing this purple with the blue, which is normally what you see mixed, the regular and the NPH, you're giving them a short acting and an intermediate acting insulin at one time, which is great if you can regulate it, but it's just harder to regulate. But they did that way back years ago to make it easy, and so that patients only had to draw up one drug and that there didn't have to be any mixing of insulin. And it was supposed to be less likely to have errors in given insulin. But the problem there is you have to find a happy medium with a dose where both work the way you want them to without one working too much or too little. Does that make sense? Did that answer your question?
yeah.
How
Okay.
does the pump work?
The pump?
Yeah, what insulin stuff?
The pump is going to work with a rapid acting that goes all the time. And we're fixing to watch a video and it's going to show you how somebody uses a pump. The pumps are really cool. Pumps are almost exclusively used for type 1. And it gives them insulin all the time at a basal rate. And then they program it to give them a bolus of the same type of insulin when they eat. So that basal in a pump is done with rapid acting insulin. They just get it all the time. But we'll watch, I'll show you this video.
Talk about the
Go ahead.
Now I was gonna ask, we're talking about the portable pump, right? That's connected.
Yeah.
They
yeah.
carry around.
Yeah. They live with it 24/7, 365.
Okay.
All right, so let's talk about insulin orders. This is probably the most confusing part of this. So I'm going to bring this up And I want you to look at it and I want you to think about it as we talk about it. You just learned why we have to have several different types of insulin unless we're on a pump. And so this is kind of what you're going to see with a lot of your patients in the hospital. And I'm going to take back what I said a while ago. I said that you're probably going to see this more with type 1s, and you do, but in the hospital, you do see it pretty frequently with type 2s where they'll be on a long-acting and a short-acting. I meant a long-acting and a rapid-acting together. So this is the typical order set that you would see. So the physician gives you a sliding scale. And for the purposes of this, we're just going to go by the moderate dose scale in the middle. Okay. So the orders are that the patient would have their blood glucose level checked, AC and HS. So before each meal and at their hour of sleep. So 4 times a day. The order also says that we're going to use the Lispro sliding scale insulin, AC and HS. So this is the sliding scale here. What does a sliding scale do?
Coverage.
It adjusts the amount of insulin based on the blood sugar.
Okay, so we're only going to give it when
it's needed. So if there's no need for the units, you don't give it.
Right. So it's only given when the blood sugar is high. Because if you look at this, if it's less than 70, it tells you to initiate the hypoglycemia protocol. And then from 70 to 130 on this scale, you're not going to give anything. So it's only once the blood sugar exceeds 130 are you even going to have to worry about the sliding scale. So it's just to correct the blood sugar if it's too high. Then we have an order for Lispro insulin AC 3 units sub-Q. So what does that mean?
They get 3 units regardless.
Okay, they get 3 units regardless of what their blood sugar is if they're going to eat. So if they're eating a meal, we're going to give them 3 units. And then we have another order for Glargine, 20 units sub-Q at hour of sleep daily. So what types of insulin do we have here?
We have basal long acting, the Glargine.
Okay.
And then the Lispro is the bolus, which is fast acting.
Okay, so we have a rapid acting and we have a long acting. And we learned that the rapid takes care of what the pancreas releases when somebody eats, and the long term provides the basal. So we're going to combine those two. So when we go in the morning at 7 o'clock, we're going to take their before breakfast blood sugar, right?
Yep.
All right. What if their blood glucose is 220?
They get 8 units plus the 3 units of Lispro.
We're going to have to go to the sliding scale and using the moderate, and we look right here. where 220 is and we go across, and yes, they're going to get 8 units. So we're going to give 8 units of Lispro because their sugar is too high. And then we're going to give 3 units of Lispro to cover their meal. So they're going to get a total of 11. So we would give them 11 units in one injection. And then at nighttime, they'd get their 20 units of Glargine. So at 9 o'clock at night, we check their blood sugar, and it is 187. Then what are they going to get?
Would it be 8 plus the 20?
8 units of Lispro. And
Yes. And the 20 of the Glargine. And we wouldn't use the 3 units sub Q of Lispro because they're not eating a meal at 9 o'clock at night. So when you have insulin, you need to look at your insulin orders, and you need to just pay very close attention. There are 2 types of drugs that we're going to talk about in Pharm this semester and in this class that have the highest number of medication errors. One is insulin, and the other is your anticoagulants. All right, so I'm not going to go ahead and play this video right now because we're already at our class end time, but I will post it. It's on this last slide, and you can play it from the slide, but what I'll do is I'll also post it under the content. But I'd like for you to look at it because it is about a day in the life of a little girl who has type 1 diabetes, who uses a pump, but by watching that video, you will learn more about how to manage a pump than I can teach you. It's something the whole family has to be involved in. And it's easy once you get used to it, but it's a lot to learn at first. But yeah, we have kids in elementary school that are managing their pumps by themselves. So, I mean, it's not like it's impossible. It just takes a little bit of time to learn it. So I will post that for y'all. And please email me if you have any questions. And I guess I will see some of you in pharmacology this afternoon, and the rest of y'all, I'll see you next week.
Thank you.
Thank you.
Okay, thank
You're
you. Have a
welcome.
good one.
All right, y'all too.
you.